Good evening, everyone. On behalf of ISVR, I welcome you all for this wonderful master class on anticoagulation management during vascular angiographic procedures. Myself, Dr. Chandrasekhar, I am a secretary, joint secretary ISVR, and I also thank President and Secretary for giving me this opportunity to moderate this master class. And today's the topic is very much essential for the practicing IAS. As you know, so many queries regarding the bleeding and coagulation persist, and you encounter during your day-to-day practice. And to address these, we have our master, Dr. Sanjeev Kumar, who is additional professor at All India Institute of Medical Sciences, New Delhi, and he has a vast experience in the interventions, and he does a lot of complex procedures including aortic and pulmonary vascular interventions, and he has over 250 publications in the PubMed indexed journals, and he has presented innumerable lectures and won many awards in national and international conferences, and he is a well-known name in the aortic interventions, and he will be speaking about the role of anticoagulation as well as managing the coagulation as well as the bleeding uh, risks during the vascular angiographic procedures. Dr. Sanjeev Kumar, please.
Thank you, sir, for your kind words of introduction. And at the beginning, I would like to thank the Indian Society of Vascular Intervention Radiology for giving me this platform to present this masterclass. So, coming to the topic, that is the anticoagulation management during the vascular angiographic procedures, which essentially means prevention of the bleeding and thrombotic complications during the peri-procedural periods during the intervention radiology. At the very beginning, I would like to stress one important thing, that the data related to the anticoagulation management during IR procedures are very scarce. And most of these are actually extrapolated from the surgical procedures. Most of the references in my presentation will be actually multidisciplinary consensus panel statement, which was published in the Journal of Vascular Intervention Radiology in 2019. And though the label of recommendation in that publication was not so strong for most of the recommendation, however, it is being widely followed worldwide and among the intervention radiology community. And until there is any paradigm changes in this management recommendation, we are going to continue following those guidelines. Just to give you a glimpse of the problem, what is problem in the peri-procedural duration if the anticoagulation is not managed. Let's look at two case examples. So this is case one, where 30-year male patient with a history of hypertension, headache, and lower limb fatigue, and with significant blood pressure difference in the upper limb and lower limb presented in the cardiology OPD. When the echocardiography was done, it showed LVH with preserved ejection fraction, and with the suspicion of the aortic coarctation in this patient, a CT angiogram was done. And as you can see on this reconstructed VRT CT image, there is a tight aortic coarctation just distal to the left subclavian artery. As per the management protocol and the guidelines of recommendation for the management of this patient was taken for the endovascular through the endovascular procedure, that is angioplasty and stenting in this patient, and through the vascular angiographic technique and taking femoral as well as the brachial axis, the lesion was first dilated, and then it was stented with a balloon-mounted self-expanding stent. So, and which leads to obliteration of the gradient in this patient. The patient was doing fine. The patient was shifted to the ward, but suddenly, a couple of hours later, patient started complaining of pain in the left upper limb. And also there was absence of radial ulnar pulses. The limb was also cold. And when ultrasound was done, it shows thrombosis of the left brachial artery. And this was attributed to the inadequate peri-procedural anticoagulation, and we know that brachial artery is prone to this kind of complications. The patient was salvaged with immediate surgical embolectomy in this patient. As contrary to this case example, let's look at this case. This is a 65-year female, had a history of mechanical heart valve replacement for aortic valve pathology, and was on anticoagulation as mandated by this procedure. Patient presented with complicated type B aortic dissection, and on this representative CT images, you can see the dissection flap with bulbous dilatation of the proximal thoracic aorta, and there was evidence of leak as well. And again, as per the protocol and the management guideline for this patient was taken for urgent endovascular repair. And again, through the various vascular access technique, femoral and brachial access in this patient. This is the angiogram. First, the angiogram was done. You can see this mechanical aortic valve at the level of the aortic root. And here you can see the tear with the abnormal dilatation of the false lumen. And then the lesion was stented with sealing of the intratear and non-opacification of the false lumen. Everyone was happy because it was a technically successful procedure, and then the patient was shifted to ward. However, suddenly, a few hours later, patient complained of altered consciousness as well as the headache. And when the CT head was done, it shows the bleed in this region. Again, various causes can be attributed to this, but one of the important causes during the peri-procedural period is poor anticoagulation management in this patient, which is resulted in bleeding in this patient because the patient was already on an anticoagulation. So when we talk about the peri-procedural management of anticoagulation, there are two groups of patients. First, as for is in the case example 1, patient on no previous anticoagulation. Here, it is important to start the anticoagulation during the procedure for prevention of pericatheter and pericyst thrombosis, and this is quite easily achievable by giving peri-procedural adequate heparinization. The second group, that is the problematic group of the patient, are patients who are already on some form of anticoagulation because of the native disease, which could be mechanical heart valve, as in the case example 2, or it could be a patient of an atrial fibrillation, it could be a patient of a DVT or pulmonary embolism, it could be a patient of an antiphospholipid antibody syndrome. It could also be patients who are taking antithrombotic treatment for coronary stent or peripheral stent. And in this group of patients, it is very, very important to assess the risk of the bleeding if the angiographic procedure is done prior to stopping that anticoagulant or an antithrombotic treatment for that matter. And if we are stopping the anticoagulant because of the high bleeding risk, whether there is an adequate protection from the risk of thromboembolism because of the native disease present or not. Also, it is important to know when to stop that anticoagulant and when to restart, and in the intervening period, whether we want to bridge it with some form of therapy or not. So we will try to look at this second case example through some of the case scenario and try to look at what the recommendation says. So moving on to this case scenario, here is a 40-year male patient who presented with a unilateral lower limb DVT, was on oral anticoagulation therapy with an INR of 2.3 for more than 3 months. And he was posted for venographic procedure. So what is your advice regarding anticoagulation management before this procedure in this patient? To give any advice, we need to answer these 3 questions. That is, the patient risk of bleeding, the risk of bleeding during the given IR procedure, which is venography in this patient, and also the risk of thromboembolism in a patient of a DVT more than 3 months of treatment if anticoagulation is stopped. So let's try to answer this question one by one. The patient risk of bleeding is traditionally being conveyed through HAS-bleed score, which is an agglomeration of various factors which include hypertension, abnormal renal function, liver function, history of any prior stroke, history of prior major bleeding, anemia, thrombocytopenia, any labile in our age more than 65 years make them a high risk for bleeding, concomitant use of drugs, and history of alcohol or any other drugs are considered as a risk factor, and each of these are actually scored 1. And when you add this score, if the score is more than 3, it is predictive of high bleeding risk for that given patient. So, if you look at this clinical profile of this patient, the clinical profile of the patient suggests that the patient risk of bleeding is low in this patient. Now let's try to calculate the risk of bleeding during the procedure, and this is a table which talks about the bleeding risk in various vascular procedures. As you can see here at this side, it's low bleeding risk procedure like a venography, IVC filter placement. And then with the increasing complexity, for example, when you want to do complex venous intervention of thoracic region or for matter, you tried fibroid embolization, it increases the risk of the bleeding. And when you go to more complex procedure like TIPS or aortic intervention, the risk of bleeding for the given procedure increases drastically, which is classified into high risk procedure. So again, if you look at this procedure, that is venography in this case, the risk of procedure is low according to this classification. So here, the patient risk of bleeding as well as the risk of bleeding during the procedure is low. So the rationalization to stop the anticoagulation doesn't arise, and we did not need to answer the third question. So the recommendation which could be given to this patient is that to continue anticoagulation therapy and to do this procedure without stopping anticoagulation within a suggested threshold of INR that should be between 2 to 3. And in this patient, the INR is 2.3. So it could be safely done. As compared to this case, let's look at this case scenario. It's a 40-year male patient and posted for diagnostic angiography. Known case of DVT, again on oral anticoagulation for last 4 months, INR is 2.3 in this patient. And then what is your advice before the procedure? We again have to follow the same algorithmic approach as we did in our case 1. So if we look at the case profile in this patient, again in this patient, the risk of bleeding is low if we look at the clinical profile of the patient. If we look at the bleeding during the given vascular procedure, which is a diagnostic angiography, it is slightly higher as compared to a venographic procedure, especially when the INR is 2.3. So definitely we cannot do this procedure at this INR because the risk of bleeding is higher as compared to a venographic procedure. So we need to stop the anticoagulation prior to doing this angiographic procedure. So now we have to assess what is the risk of thromboembolism if anticoagulation is stopped in this patient who is taking anticoagulation for more than 4 months for the DVT. So to calculate the thromboembolic risk, this is the suggested table which classifies the patient into a low, moderate or high risk for thrombosis. And this is called as the traditional CAD-VAS score, which includes various criteria like gender, presence of any congestive heart failure, history of diabetes, hypertension, vascular disease history in different vascular territory, ages, and any prior history of a stroke, TIA, or thromboembolism. Again, based on this point, they are scored, and a score more than 7 is considered as a high thrombotic risk. Also, patients with a mitral valve prosthesis are considered in a high risk group. Patient with antiphospholipid syndrome is considered in a high risk group, or for that matter, cancer-associated thrombosis is also considered in a high thrombotic risk if you stop the anticoagulation. However, a patient who is being treated for venous thromboembolism for more than 3 months for provoked DVT is considered under the low risk group. And this patient was being treated for more than 4 months. So here, even if you stop the anticoagulation, the risk of thromboembolism is quite low. So the management recommendation in this clinical scenario could be given that stop the anticoagulation for 3 days so that the INR reaches below the threshold of 1.8, and then to do this procedure safely without giving any bridging therapy in this patient. Let's look at this another case scenario. This is a 67-year female patient, hypertension, posted for TIPS procedure, and is a known case of mechanical mitral valve on oral anticoagulation for last 6 months. And so what is your advice for the anticoagulation management? If we look at, again, if we follow the same algorithmic approach, that is assessment of the patient risk of bleeding during the procedure, and then answering the thrombosis risk. Here, because of the age and the presence of hypertension, the bleeding risk is slightly higher as compared to the last 2 cases. Also, TIPS is categorized in high bleeding risk procedure. So the answer for both this question is actually high. So definitely we need to stop the anticoagulation before doing this procedure because the risk of bleeding was high. Now we have to answer the third question, that is the risk of thrombosis if we stop the anticoagulation in this patient of mechanical mitral valve. And again, if you look at that table which we have seen in the previous case example, you can see that any mitral valve prosthesis carries high risk of thrombosis if you stop the anticoagulation. So the management recommendation which could be given in this patient is that stop the anticoagulation for a period of 5 days, bridge it with heparin therapy because of the high risk of thrombosis, recheck the INR at least 24 hours prior to the procedure to look at the threshold of the INR so that it should be less than 1.5, which is suggested for a high vascular risk procedure. And once it is achieved, you do your procedure. So this is the algorithm actually which talks about the management of the patient who is on anticoagulation, and depending upon the risk of bleeding, if the risk of bleeding had been low, we can do the procedure with current anticoagulation. And if the risk of bleeding is high, we need to assess the emergency of the procedure. If the procedure is emergent, we need to consider for the reversal agent. And if the procedure is not emergent or elective, again, we have to assess the risk of the thrombosis. And if the risk of the thrombosis, for example, in the mechanical heart valve is high, we need to bridge. Otherwise, we can just simply stop without bridging and do the procedure after a certain period, that is 5 days for warfarin. Moving on to the next case example, this is a 66-year male, hypertensive, posted for aortic intervention and a known case of coronary artery disease with stent in the multiple coronary artery, and patient was on dual antiplatelet therapy for last 3 months. Now, what is your advice before the procedure? Again, if you follow the same step as we have followed for the last 3 cases, here considering the age and the hypertension in the patient risk of bleeding is slightly higher. If you look at the procedure risk of bleeding here in this case, which is aortic interventions, which is again in the higher range. As compared to the last 3 cases where we talk about anticoagulation treatment, in this patient who had a coronary artery disease and on multiple stents, this patient was on an antithrombotic treatment, that is antiplatelet treatment of dual antiplatelet therapy, and this patient are again prone for bleeding. Now we have to assess that if we stop this antiplatelet treatment, what is the risk of thrombosis of the coronary artery stents? So if we look at this diagnostic algorithm of a patient who is being posted for some IR procedure who are on dual antiplatelet therapy, if the risk of the bleeding is low, we can just continue with the dual antiplatelet therapy and can do the procedure. But if the risk of bleeding is high, for example, in this case of aortic intervention, we have to know when the stent was placed. If the stent had been placed more than 1 year period, then we can stop one of the antiplatelet and can continue with the aspirin and can do the procedure. However, if the stent was put on earlier less than 1 year, we need to have a multidisciplinary consensus and recommendation and advice from the concerned clinical department, which was cardiology in this case, to know how to manage the antiplatelet therapy during this peri-procedure period. So moving on to the, so having understood the different case scenario, it's also important to understand when to restart with anticoagulants after we have done the procedure. So this is the suggested algorithm. Again, we have to look at the risk of the bleeding post-procedure. And if you think that the risk of bleeding post-procedure is low, then we have to assess the indication for the anticoagulation. If it is an atrial fibrillation, we can start anticoagulation without bridging in most of the patient. While a patient with a mechanical heart valve will require bridging and then start of the anticoagulation. While in a patient of venous thromboembolism, depending on the acuity, if it is acute, we may require to bridge it with bridge and then start the anticoagulation, while in the chronic cases, we can just start the anticoagulation without bridging. While the patient who continued to have a high risk of bleeding post-procedure, again, we have to assess the thrombotic risk in a given patient, and if it had been low, we can hold the anticoagulation for a certain period of time as long as the risk of bleeding decreases. And if the thrombotic risk is high, then we have to consider bridging with maybe some form of anticoagulation. The most commonly used is unfractionated heparin. So having understood the various case scenarios and the management recommendation of the anticoagulation and the antiplatelet in different vascular intervention procedures ranging from the low risk to high risk, and when to restart this anticoagulation after the procedure, let's go to the very basic, hit the bull by its horn. So what I mean is that let's try to understand the basic of the bleeding and thrombosis when you do certain procedure. That is, when you made a puncture through the skin and you enter the blood vessel, it initiates a coagulation cascade. What is this cascade all about? So this cascade actually consists of two hemostatic pathways, that is the primary and secondary hemostasis. And you can see in this schematic representation, this is the representation of a blood vessel. These are the layers of the blood vessel, and this is the lumen. And when the blood vessel wall is punctured or injured, what it do immediately is that there is an activation of the primary hemostasis, which consists of vasoconstriction of the vessel, platelet adhesion, activation, and then the formation of the platelet plug. So any platelet dysfunction, any platelet thrombocytopenia, or any use of antiplatelet drug can affect this primary hemostasis. Similarly, after primary hemostasis, there is the activation of the coagulation cascade, the coagulation factor, which leads to formation of a secondary hemostatic plug, that is addition of fibrin over this platelet. So any defect in the coagulation factors can result in destabilization of this secondary hemostasis plug and can result in bleeding in this patient. So when I say about this secondary hemostasis, what I mean is to say the activation of this coagulation cascade, which consists of an extrinsic pathway, which get activated by release of tissue factor once the vessel is entered or injured, and the activation of intrinsic pathway simultaneously by activation of factor 12 when it comes in contact with the collagen, and then it results in a chain reaction with activation of different coagulation factors coming to the common pathway, and then finally conversion of fibrogen into fibrin clot and resulting in a formation of a stable hemostasis in a given patient. So when we talk about different antiplatelet agent which acts through different receptors, it can actually disrupt the formation of the primary plug, that is the primary hemostasis, and can result in continued oozing or bleeding in a given patient during the procedure as well as the post-procedure. Similarly, the different class of anticoagulants like the heparin, which acts on the intrinsic pathway, the oral anticoagulant like the warfarin, which acts on the extrinsic pathway, or the newer anticoagulants like rivaroxaban, which acts directly on the factor 10, or maybe direct thrombin inhibitor like dabigatran, which acts directly on the factor 2. So all of this can alter the coagulation pathway and can result in abnormal bleeding in given patient. So most of the management recommendations which are being formulated for peri-procedural IR procedures is based on the pharmacokinetic property of these agents. So that what I mean is that knowing their half-life, knowing their clearance from the plasma, knowing their mechanism of action, knowing when they are cleared from the and what is the mechanism of clearance from the body is very, very important if you are planning a management recommendation for any given drug. What I will do is that I will go through most common anticoagulant, that is the heparin and the warfarin and their pharmacokinetic properties, and will try to explain how it impacts the management recommendation during the vascular angiographic procedures. So when we talk about the heparin, you know that it is a heterogeneous mixture of polysaccharide chain, mainly glycosamine glycan, and its molecular weight varies drastically from 3,000 to 30,000 Dalton units. And it has also got very variable binding to plasma protein, macrophages, and endothelial cells. And because of this variability, it is only biologically active 1/3 and mainly administered parenteral. So if you look at the mechanism of action of the heparin, what it does is that it potentiates the action of the antithrombin. It has got multiple ligand binding site and then complexes with the thrombin to deactivate it and resulting in non-formation of the fibrin in a given patient. It also had other mechanism. It can also directly inhibit platelet aggregation as well as activation of other clotting system in the coagulation cascade. If we look at the half-life, it is 60 to 90 minutes. However, it is non-linear and dose dependent. This is important for whosoever is using heparin. It has got a rapid and saturable mechanism where it binds to the cellular receptor, internalized and degraded, and then there is a slow and unsaturable mechanism of degradation through the renal clearance. So when you are giving a higher dose or when you are prolonging your procedure, the half-life also increases. It doesn't remain same as 60 to 90 minutes. So this is important. Various dosing regime had been proposed based on the weight or absolute bolus doses. I'm not going through that. But what you have to remember is that if you are doing a concomitant fibrinolytic therapy, the doses should be reduced as it can result in hemorrhagic complications. So as opposed to newer anticoagulants where monitoring is mostly not required. However, for when we talk about heparin, monitoring is important because it's because of its problem with the bioavailability. And when you talk about the monitoring, it also has got a narrow therapeutic range and can increase the risk of bleeding. So monitoring is very much essentially required. And when you look at this flow chart, it acts on the intrinsic pathway and can be monitored through the ACT or APTT. So if you look at this slide, this talks about the normal value of the APTT, that is activated pulsar thromboplastin time, and the therapeutic range. And similarly, you can see here the activated clotting time and the therapeutic ranges. But what is important to remember that which one you will choose when you are planning to do a procedure or when your procedure is prolonged. So as you can see on this slide that the effects of heparin are non-linear when we are using APTT as a measure. So it's less accurate, especially when your procedures are prolonged and you have given much of the heparin. In those cases, ACT has got a linear relationship and it's assess the overall coagulability in a given patient. And it's also readily available. So ACT should be used whenever you are doing a prolonged procedure with a higher dose of heparin in a given procedure. When we talk of the elimination, because of its short half-life, the natural elimination occurs within 4 to 6 hours. So if you have to stop heparin before a high-risk bleeding procedure, you can stop it 4 to 6 hour procedure before the last dose. But if you want to reverse it urgently, then the protamine may be used, and the doses which have been suggested for the protamine is 1 milligram of protamine for 100 units of heparin. But again, you have to remember one important thing: because of its short half-life, you have to calculate the dose of heparin which has been given in the last 1 or 2 hours and not the whole dose for choosing the amount of protamine. Some of the complications you must know. I think one of the important is heparin-induced thrombocytopenia, and you should suspect in any patient who is being on heparin therapy, who develop a systemic thrombosis or bleeding complication, you should think of this etiology in that given patient, and the heparin, if the diagnosis is established, need to be immediately stopped to avoid further complications in those patients. Moving on to the derivative of the heparin, that is the low molecular weight heparin, and because of the variability in derivation, it has got multiple commercially available forms, and it is a more homogeneous mixture as compared to heparin, that is unfractionated heparin, and the weight is also more homogeneous. It has got less binding to plasma protein, macrophages, and endothelial cells, and hence it has got more predictable dose-response relationship as compared to heparin, and also a better bioavailability of 90% as compared to heparin, which has got only 30 to 40% bioavailability. So it has got slightly different mechanism of action. It directly inhibits factor 10 as opposed to the heparin, which potentiates the antithrombin 3. So if you look at the half-life, the prototype, that is the enoxaparin, it has got a half-life of 4.5 to 7 hours. So if you want to empirically stop low molecular weight heparin before a high-risk procedure, 24-hour, stopping 24 hours prior to the procedure is an acceptable range. But however, it has got more of renal clearance and it has reduced binding to macrophages. So we have to look the renal function in a given patient. And if the renal function is less than 30 milliliter per minute, then the whole time for the low molecular weight heparin will also increase to reduce the bleeding complications. And again, these are some of the dosing recommendations for different group of patients. But what is important to remember is that if patient had a renal dysfunction, we have to consider for lower dosing in those patients. And as I already said, because of the predictable pharmacokinetics, monitoring is most of the time is not required, and in certain situations, if it is required, a direct estimation of anti-TNF factor could be done to know the level of the low molecular weight heparin. Antidote protamine, though used for heparin, is not as effective as or predictable. However, we can use it if we want urgent reversal of low molecular weight heparin as well. And the doses are usually calculated based on the anti-TNF units, and generally 1 milligram of protamine is considered to be equivalent for 100 anti-XA units for neutralization. And by now we know that low molecular weight heparin doesn't require lab monitoring, has a higher bioavailability, longer plasma half-life, and it also doesn't inhibit platelet function. And one of the dreaded complications that is hit is also low in this group of patients. Moving on to the oral anticoagulants, that is the warfarin, which is a synthetic derivative of dicumarol, and it is water soluble, rapidly absorbed, and have very high bioavailability. If you look at the half-life, it is 40 hours. So the terminal half-life is around 1 week, and it is mainly degraded in the liver. If you look at the mechanism of action of warfarin, what it does is that it antagonizes the vitamin K dependent factor, which is being synthesized in the liver, mainly 2, 9, 10, and 7 factor, and it also antagonizes anticoagulant factor, that is the protein C and protein S. So when you give warfarin initially, it antagonizes much more the anticoagulant factor. So initially it acts as a prothrombotic. And then later on, when it inhibits the other coagulation factor, it becomes an anticoagulant. If you look at the testing, it mainly acts on the strength pathway and can be monitored through the PT and INR. And these are some of the values of the normal prothrombin time and the INR in the given patient. And depending upon the different pathology, the INR could be variable, or the therapeutic INR could be variable in different conditions. Optimizing warfarin therapy is a challenge because of its different absorption rate and different bioavailability according to different patient. And the doses are initiated as per written in the slide. So you generally start with this lower dose, and once the INR is achieved, then you try to maintain with the maintenance dose. What is important to remember is that because it has got an initial procoagulant effect, it's always good to start with heparin so that it does not cause a prothrombotic state when it is started, and then after continuing it for 4 to 5 days, you stop the heparin so that there should not be synergistic effect. But before discontinuing, we should measure the INR to assess that it has reached in the therapeutic range. And among the various complications of warfarin, we should remember that pregnancy, because of the relative teratogenic effect, has been considered as one of the contraindications for warfarin therapy. So if you want to do a procedure and the patient is on warfarin, the natural elimination will occur in the 5 days. So generally we say that to stop the warfarin 5 days prior to the procedure. But if you want to do an urgent procedure and the patient is warfarin, plasma is generally given at the rate of 15 ml per kilogram of the body weight. Vitamin K also helps in reversal of the effect of the warfarin, but it is not as rapid as the effect of the plasma. Now when you are seeing a lot of prescriptions which are coming to you, many of these patients are actually on the newer anticoagulants, which we call as novel oral anticoagulant therapy. And if you look at this chart, you can see that some of them act directly on the thrombin and inhibit it. The example is dabigatran. And then there are certain oral inhibitors which act on the factor 10, like rivaroxaban, apixaban, and so on and so forth. So what is important that you should remember that this agent have got a very predictable anticoagulant effect, and hence monitoring is generally not required as opposed to warfarin where monitoring is very, very important. Also, it had got a wide therapeutic window which reduces the chances of bleeding and other complications in this patient. And also, it has got a rapid onset as opposed to the action of the warfarin. It takes much shorter time to achieve the therapeutic level, and the offset is also slow. Hence, when you are using a new novel oral anticoagulation, heparin bridging is mostly not required. And also these drugs have minimal interactions, so these drugs are now more and more preferred in majority of the situation where anticoagulation is required. And this table actually shows you the recommendation for these drugs for low risk bleeding procedure as well as high risk procedure depending. And I will suggest everyone to go through this chart to understand each and every drug, and these are largely based on the pharmacokinetic property of a given drug. And similarly, we know a lot of antiplatelet agent based on the different mechanism of action. And then again, this is one of the table which talks about the when to stop and when to start with an antiplatelet agent. And these are also based on the pharmacokinetic property. So knowing the pharmacokinetic property of this common drug is very, very essential. So normally this question arises, what coagulation test we should do prior to any vascular angiographic test? And if you look at the low bleeding risk procedures, generally coagulation testings are not required unless and until the patient is on some form of anticoagulation. And in those, it is suggested that to correct the INR in the range of 2 to 3 if you are doing a venographic procedure. And if you are doing some diagnostic angiographic procedure, it is suggested to correct the INR for less than 1.8. And if you are using a radial axis for doing the procedure, some diagnostic procedure, we can safely do those procedures with the INR less than 2.2. And the platelet threshold in those situations is less than 20 lakhs. Similarly, for the high-risk vascular procedures, it is generally suggested that we should do a INR and platelet count or PT. And then the threshold for this kind of procedures is to correct the INR less than 1.5. And then the platelet should also be, should not be less than 50,000 as per this procedure. So is there any role of thromboelastography? Thromboelastography is very, very important when we talk about certain special group of patients, especially the chronic liver disease patient. In this group of patients, there is a rebalance of hemostasis. What I mean to say is that though because of the liver damage, there is a deficient formation of the procoagulant factor, but also the anticoagulant factors are poorly formed. And the von Willebrand factor is not synthesized from the liver, which enhances the platelet activity. So in a patient of a chronic liver disease, the platelet will be better functioning as opposed to a normal patient because of the unopposed action of the von Willebrand factor. So the threshold which has been suggested for doing this patient in the patient with a chronic liver disease is different. As you can see that for high bleeding risk procedure, the suggested threshold for the INR is less than 2.5 as opposed to a normal patient where we suggest a threshold of less than 1.5. Additional testing has been suggested to assess the level of the fibrinogen. And they say that if the fibrinogen level is more than 100 milligram per deciliter, this suggests a good coagulation parameter in that given patient. Similarly, chronic renal disease patient is another group of patient where there is a, because of the anemia as well as platelet dysfunction, this patient are at a higher risk of bleeding. Also, because of the renal disease, many of the drugs which have got a renal clearance get prolonged and remain in the blood for a longer period of time. So we should try to have a higher threshold for the platelet in patient with the chronic renal disease, and additionally, we should consider for additional hold time for those agents which are being primarily excreted through the kidney. So this is, I think this is my last slide, and this is the summary of what we have discussed. That so patients who are on anticoagulation management, try to assess the procedural bleeding risk. And if the bleeding risk, for example, venography or diagnostic angiography is low, perform your procedure without stopping the anticoagulation. And patients who are being high risk or moderately high risk, again, assess the risk of anticoagulation cessation. And if you think that the risk of anticoagulation cessation is very high, then you should always try to bridge those patients. And the patient where the risk of anticoagulation cessation is low, we can stop the anticoagulation and can do the procedure without the bridging therapy. So I would like to come to this slide. This whole of the topic seems quite complex, like this balancing act. You can see if somebody will ask you to do this kind of job, it will sound terrible. But when you see an expert like this, who know how to balance it, you can be master of it, and you can prevent majority of the complications which arises because of the poor anticoagulation management during the vascular angiographic procedures. So with this, I thank you all for your patience hearing, and I think we can have questions as well.
Thank you, Dr. Sanjeev Kumar, for this excellent lecture. And it's quite a complex topic, and he made it all the relevant points very clear. And is there any questions? Anybody can type their questions in the chat box. I will just take it. Okay, if there is none, Dr. Sanjeev Kumar, I have a few questions. Do you think we need to have a platelet measurement done prior to angiographic procedures?
So,
is it necessary or not?
So as I already said that before a low bleeding risk procedure or a patient who had no major comorbidities, platelet measurement is not required. But as opposed to that, a patient procedure which has got a high bleeding risk, for example, a patient posted for TIPS, a patient posted for aortic intervention, or for that matter, patient with chronic renal disease. In these patients, actually, the platelet count, the platelet are dysfunction, there may be some thrombocytopenia. So in this group of patients, actually, platelet should be routinely measured prior to the vascular procedure.
Does it affect the thrombosis effect of like coiling and all those things, the platelet?
No, if you look at the mechanism of action of the coiling, if it is a non-fibered coil, they act by mechanical occlusion. And most of the coils actually act by mechanical occlusion, and the fiber which is being attached to them help in thrombosis. So it will not have much effect in terms of achieving the therapeutic goal.
Like many of the heparin and all those things have a reversal agents. Do you know any antiplatelet? Is the if patient is on antiplatelet drugs, is there any reversal agent for those?
So generally for the antiplatelet agents, we generally prefer to give platelet concentrates. So this platelet, so 1 unit of platelet concentrate actually improves platelet by 5,000 units. Normally 6 units of platelet concentrate will achieve an increase in the platelet concentration of 30,000. So normally if you are doing a high risk bleeding procedure and the platelet count is low, we should think of infusing with platelet concentrate. There is no, there are certain antagonists which are available, but it's not available freely, and they are mostly in the research stage. So PC platelet concentrate is the way to go in those situations.
And what about the bridging? Is it when you do the bridging, is it associated with excess bleeding anyway?
So that's a very important, good question or important question, I would say. And there are a lot of actually studies which have been going on regarding the role of bridging. But unluckily, most of these randomized trials are looking at the surgical procedure. And in many of these trials, they have found that the bridging is not helping in any other way in preventing the thrombosis, but at the same time, it is increasing the risk of bleeding. So there may be time will come when this bridging, which is being overrated in many of these conditions, will no longer exist.
And you rightly said the heparin when half-life increases as the dose increases. Then how to assess when to give the extra heparin, and what is the maximum? Is there any maximum limit where limit of heparin we can give to the patient?
So if your procedure is prolonged, we can just do a ACT, and we should try to keep our ACT between 2 to 250. So if that is there, we don't need to give extra heparin. But if the ACT is falling below 200 during the procedure, we can always give heparin based on the body weight.
Okay, one silly question you may say, because supposing a patient is on low molecular weight heparin, already patient is on low molecular, why we need to stop? Actually, we can continue the procedure without giving the heparin in the intra procedure. Did you get my point?
Okay. So you are saying that patient is on the low
molecular heparin.
So if you are doing a low risk procedure, you can actually continue. You can actually continue with
low risk independence diagnostic angiography.
Yes, diagnostic angiography, venographic procedures.
No, without giving the unfractionated heparin during the procedure.
Yes, that could be done. That could be done.
Okay, basically, yes, you are right. But basically, unfractionated heparin has a reversal agent, so that LMW has the reversal agent, and
if by some reason that has not been done, and you have to do a low risk procedure, there is no need to stop. But if it had been a high risk of procedure, then we may need to stop it.
Okay, if a patient is hypertensive, diabetic, cancer patient, all the bleeding score very high, and you want to do the venogram low risk procedure wise, do you recommend the stoppage of? How do you recommend manage the anticoagulation and stoppage of the dual antiplatelet, warfarin, all those things?
See, so if you are doing a venographic procedure, mostly if you are doing from the femoral axis, it's easier to control the bleeding even in a high risk patient. But and see, these are all the practical things. I mean, the recommendation clearly says that even if the patient had a very high risk of bleeding, you may want to slightly optimize the INR. Keeping the INR at a very higher rate, even it can lead to oozing after your hemostasis has been achieved at the venous site also. So we have to look at the check and balance and try to keep the things in a optimal range. I mean, there is actually no clear-cut answer to this question, and all this situation need to be managed individually.
Yes, exactly. Yes, please carry on.
No, exactly. That's what I am saying. That everything could not be managed by recommendation. As I already said that even if you look at this SIR guidelines, most of these recommendations, if you look at the strength, they are weak. And they had been largely been extrapolated from the experience of the various experts. So, but if your experience is different, you can always follow your experience.
Yes, actually, in the meantime, the definition of low risk procedure is the areas where bleeding is very easy to diagnose and where we can easily control. Like superficial lesion, irrespective of any bleeding complication, we can do. Actually, we can control by compression, all those things. Or if we can pick up early, like a breast biopsy, even no need to do, no need to have any prior investigation, despite a cancer patient or hypertension, all those things, because it can be easily controlled by compression only. It's a superficial, any intervention, it can be done easily. And
yes, sir. Rightly said, sir.
Thank you, Dr. Sanjeev. Any questions? Just I will go through the questions. Sorry. What should be the appropriate INR for radial access?
So radial, I have already answered this. It should be less than 2.2.
Yes. Okay. And I urge all of you to read the SIR guidelines. There is a good JVR issue where recommendations are clearly defined, and those two articles are must read for all our IRs. And what you do if you encounter HIT? Should one completely stop heparin?
Yeah, that's a heparin is no in that situation. You should immediately stop heparin, and if certain antithrombotic agent is required, we should switch on to some direct thrombin inhibitor like dabigatran or maybe bibilirudin in those situations. Heparin is no in that situation. It will further potentiate the complication.
What is the role of NOAC in ALI?
And what NO?
NOAC, oral.
Achha, okay. Nova ALI.
ALI, acute limb ischemia.
ALI, we generally in the acute limb ischemia, there is a role of unfractionated heparin more than, the most widely used agent is actually unfractionated heparin. Yes, we can use in those patients where there is issues like a patient who had got a heparin anaphylaxis or had developed HIT in the previous institution of heparin. In those situations, a NOIC like a DTI inhibitor, IV DTI inhibitor like a bivalirudin could be used.
Patient with acute limb ischemia due to popliteal occlusion, post CDT for 48 hours and heparin infusion now with residual clots in distal ATA, PTA and peroneal. What is the anticoagulation management you advise?
So most of these patients are being after heparin. Most of these patients are now being converted into direct oral inhibitors. Most of these patients are given either a rivaroxaban if the patient can able to afford. The problem is also the price of those agents, and if they are not able to afford, then warfarin could be advised in those patients.
For kidney biopsy in CKD patient, what INR and platelet count is necessary?
So kidney biopsy actually goes beyond the vascular intervention, but still it is a organ which is not directly in access. So if some bleed occurs in a deep-seated solid organ biopsy, any solid organ deep-seated organ biopsy will be considered under high-risk procedure, and a high-risk management guidelines should be followed.
Okay, I think we have covered all the questions, Dr. Sanjeev. Thank you very much, and you were the best person to explain all the queries. And if any queries, you can mail us, or Dr. Sanjeev Kumar will be happy to revert back with the good answers. And I urge you to go through those two articles of SIR guidelines, very informative, very crisply written, and each word is very practical tips for practicing IR. Thank you, one and all. Thank you, Dr. Sanjeev.
Dr. Sanjeev, I just want
Yes.
to make a comment. I'm Dr. Arun Gupta. Hi.
Hello, sir. Hi, sir. Good evening.
So basically, you very clearly highlighted that the patient who are having liver disease are entirely different from a normal patient. Their INR and their platelets are very different, and you very categorically categorize that the platelet which we see because of they are actually better functioning platelets in that. And so for many of the procedures, it's generally because they usually have a high INR and low platelets. We should not try to correct those INR and platelets and those patients, and should understand that their INR is basically it's a combination of prothrombotic and antithrombotic stage. So possibly INR of 2 is nearly normal in that particular patient, and you should plan the procedure according to that, keeping this point in time.
Yeah, right. That's rightly said, sir. That's actually that has shown that if you follow the INR and do plasma infusion or platelet infusion, many of these patients will die because of portal hypertension, the CLD patient volume overload, and they will die. So
Correct.
never try to follow that schedule. Always try to look at the whole clinical perspective, and that's why here comes the understanding the basic pathophysiology, the basic mechanisms, understanding the coagulation cascades. All these are important.
And if you're still in doubt, I think it's there is a test called thromboelastography.
Yes,
which clearly tells whether that CLD patients require platelets, FFP, or any other abnormality. So if you are in doubt, you are unsure, or doing a high risk procedure, take the help. It's not very costly procedure. And you have also highlighted the fibrinogen level. They are also very important in considering whether the patients require fresh frozen plasma.
Yes, yes, sir. That's rightly said again, because most of the tests, conventional tests which are available, they only measure the effect of the procoagulant factors. They don't take into account the anticoagulant factor as well, which are present in the system. But this thromboelastography is a dynamic test which measures the kinetics of the clot formation and the time of the clot formation. So if your thromboelastographic test is normal in a given patient, even if the INR is 3, you don't require to do anything in those patients. That's the beauty of the test, though, but actually those tests are not available everywhere. That's the problem. So in those situations, fibrinogen could be handy in many of these situations.
Dr. Sanjeev, this raises one query from my side. It is about chronic liver disease. What about the acute liver disease? Will that holds true for acute liver diseases with the abnormal liver functions?
See,
like hepatitis, all those acute liver diseases.
So it depends upon how long is the disease being affected. If it has been only few days, still there will be a lot of the coagulant factors which have got a half-life. But if it has over a period, if the liver disease has prolonged over a period of time, then it's going to affect all the factors which are present. So if it had been a 1 or 2 day duration, it will not hold true. Same thing. But it had prolonged over a period of more than 7 days, then it holds true.
Okay. Thank you. Any more questions? If none, Dr. Sanjeev, I thank you from ISVR side, and I appreciate your time, especially in this Diwali weekend, and highlighting all the essential points of this anticoagulation. Thank you. Thank you very much.
Sir. Thank you, everyone.
Thank you, one and all.
Yeah, thank you, sir. Thank you very much.